Good morning, everyone. We all know cataract and diabetes, they goes hand in hand, and also that there are increased incidence in the cataract surgeries in diabetic patients with normal variations. So this Framingham study has showed that there is 3 to 4 times higher occurrence of cataracts, and it is now the principal cause of legal blindness in early onset diabetes patients. And up to all the cataract patients we operate, 20% of them are the diabetic patients. So this is why the pathophysiology of the cataract is, it is because of the glucose aldose reductase, which causes sorbitol, which is retained within the lens capsule and causes the swelling and the opacification. Now, why it is a therapeutic challenge? Because of the anatomical variations which we see in patients with diabetes. So, the cornea in diabetic patient has increased epithelial fragility, altered epithelial and endothelial functions, reduced cell density and the corneal sensitivity, which leads to epithelial defects, corneal edema, impaired wound healing and refractive surprises post-surgery. Iris also behaves differently because it is more rigid and there are more chances of neovascularization of the iris and the angles, which leads to miotic pupil during the surgery, pigment dispersal on the cornea and the trabecular meshwork, iris bleed and also severe fibrinous reaction. Lens, yes, it also behaves differently as we can see the transient cataract of hyperglycemia. More chances of PSC is seen in these in diabetic patients, and the lens capsule is more fragile, leading to difficult capsulorhexis, anterior capsular contraction post-surgery, and zonular instability during the surgery. Now, what are the concerns after the cataract surgery in patient with diabetes mellitus? We see that there is more severe fibrinous reaction in about 10% of the patients who underwent cataract surgery. So we need to rule out whether it is TAS or endophthalmitis, and we can prevent it by making it a more traumatic surgery and aggressive topical steroids post surgery. Delayed wound healing, we all are aware of delayed wound healing in all diabetic patients. It is because of the tear film changes, conjunctival changes, also the cellular dysfunction of the cornea and abnormal adhesion of the corneal epithelium to the basement membrane. Fibrotic type of PCO is more commonly seen in diabetic patients, which is usually seen 18 months post-surgery, and we can prevent it by polishing the posterior capsule using hydrophilic lenses and large square edge lenses. Post-op infection is seen in almost 21% cases after the surgery, which are culture positive in 79% and gram negative in 18.5% of the patients. Preoperatively, we should thoroughly examine the patient, control the systemic parameters, and maybe we are still in doubt whether pre-op antibiotics helps in these cases or not. Intracameral antibiotics are more in use to prevent endophthalmitis in such cases. Progression of neovascularization of the iris is seen mainly because of per se the cataract surgery, or it can be seen if there is pre-op active proliferation in the patients, which is seen in 40% of the patients. Now, regarding the progression of the diabetic retinopathy, there is a conflicting literature. Some says yes, there is clear progression, and some says there is no progression related to the cataract surgery. While the progression is seen in 10 to 30% of the patient, it is still in doubt whether it is because of the surgery itself or the natural course of the disease. It is thought that it happens because of the blood-ocular barrier, which is disturbed and causes alterations in the various chemicals and the molecules present in the eye. So what are the risk factors? It is the poor control, patients on insulin therapy, pre-existing retinopathy which is not treated, and the traumatic surgery. DME also gets precipitated in patients who underwent cataract surgery, and it is seen that if we operate a patient, if it is successfully treated before the surgery or there is no CSME before the surgery, that in 50% of the cases it resolves spontaneously, while if the CSME is established during the surgery, it is unlikely to resolve spontaneously. We should always do a complete systemic evaluation before taking the patient for the surgery. Now, if we go by the older concept, it is like avoid the surgery if the vision does not drops beyond below 20 by 200. But because of the newer advances, we can operate the patient early because of the demands also. So now let's see of various case scenarios. The case scenario one, if there is only cataract, no diabetic retinopathy or mild to moderate retinopathy with stable or treated or stable diabetic retinopathy, we can go with the routine cataract surgery and repeat fundus evaluation post-op. In case 2, if there is a patient with cataract and severe NPDR or early PDR and you can see the retina, then always treat the diabetic retinopathy before taking the patient for the cataract surgery. In scenario 3, if there is a patient of cataract with severe NPDR, but you cannot see or there is a limited fundus view, do the OCT if possible, and if there is no view, always do a B scan and assess the posterior segment. You can alter your plan of treatment depending upon the OCT findings and the B scan value. In another case, if there is no view of the fundus along with the cataract, again you have to do the B scan, assess the posterior segment, and if there is no opacities or minimal opacities, then you can go ahead with the cataract surgery and then do the evaluation post-surgery. And if yes, you find that there is moderate to severe opacities with tractional or combined component, then always plan for a combined surgery in such cases. Now, if you see a patient with cataract with DME, then again same, you have to treat the DME first and then take the patient for the cataract surgery. But yes, if there is a significant cataract, we can plan pre-op or even the intra-op anti-VEGF use along with the cataract surgery. But yes, always be beware of Irving-Gass syndrome, and we need to differentiate it from the diabetic macular edema or the Irving-Gass syndrome post-surgery. So what are the intra-op challenges? Yes, it starts with the anesthesia, incision and wound construction, and the corneal protection. Also, we need to be vigilant about the pupillary dilatation during the cataract surgery. Capsular exits should be large. We should avoid the small capsular exits. Phacoemulsification, we should use the minimal phaco energy and low flow settings because the capsule is leathery and sticky cortex and the hard nucleus. IOL, preferably it should be in the bag, and hydrophobic acrylic IOLs should be used. Monofocals are preferred over the multifocal lenses. So post-op care, yes, as these eyes are more prone for the fibrinous reaction or the endophthalmitis, we should use the topical NSAIDs or the steroids more compared to the routine cases. In case, as I have already told, that if depending upon the type of the retinopathy which was present before the surgery, you should evaluate the patient and treat the patient accordingly. So what are the poor visual outcomes indicators is the pre-op visual acuity, presence of the CSME or the severity of the diabetic retinopathy. Now coming to the combined surgery. We can also combine the vitrectomy and the cataract because it is seen that there is progression of the cataract in 75% of the patients who underwent only the vitrectomy and not the cataract surgery. It is because of the procedure per se or the gas cataract. So what we can do is option 1, we can do the cataract and later the vitrectomy, but it delays the management of the vitreous disease and late visual rehabilitation. While if you go for the vitrectomy first and later the cataract, then it can lead to the poor vitreous management because of the impaired view, difficult post-op monitoring of the retina, and also the second surgery is needed in such cases. Difficult phacoemulsification in vitrectomized eyes, and also the lens iris diaphragm retropulsion syndrome is more commonly seen if the patient has undergone vitrectomy first and then the cataract. And the last option or the better option is the combined surgery. It has the advantage of single operation, good visualization, and simultaneously tackling both the pathologies. So my take-home message is, pre-op, we should always evaluate thoroughly the patient's ocular and the systemic condition. Treatment of the associated diabetic retinopathy and diabetic macular edema before taking the patient for the cataract surgery. Intraoperatively, we should be beware of the anatomical behaviors of the various tissues like iris, cornea, lens, and also we should be more vigilant in taking the post-op care of such patients because of the more chances of fibrinous reaction or the endophthalmitis. Thank Thank you so much.
Thank you, Dr. Shilpi, for highlighting the importance of pre-op evaluation of fundus in a case in a diabetic eye when you are considering the cataract surgery. And equally important is the pre-op evaluation and thereby management before you do a cataract surgery. Very well highlighted. Thank you.